Welcome back to our class. So first is oral ulcer. How many students we have? 11. Okay. So oral ulcers are generally classified as two types. For oral cavity, there are two types of ulcers. One is multiple ulcers, and the other one is recurrent oral ulcers. So we have multiple and recurrent. There are single occurring ulcers, usually by viral infections, but mostly generally classified as multiple and recurrent ulcers. And then multiple is further divided into acute multiple and chronic multiple, depending on the onset of the ulcers. How many we have? 12, still 12. Anyways, we'll just go slow and then hope others join. Okay, so on the right side of the screen, as you can see, there are some causes of mouth ulcers. For example, sensitivity to acids, acidic food such as lime, pineapple, strawberry, excessive use of lemon water. And then in the last slides, we have covered viral and fungal infections. And then dental braces, these dentures exposed to the inner side of lips and mucosa, mucous membrane, can cause some blisters, which later can turn into ulcers. And then mouth wounds caused by toothbrushing and accidental biting of the lip, if not taken care, can turn into ulcers. And then lack of vitamins, especially B12, folate, and iron. These are some of the causes, major causes of mouth ulcers. Next. So first we will have a look at acute multiple ulcers. So acute multiple ulcers include oral ulcers caused by these diseases or these pathogens, viruses you have already studied. But now we'll focus on the oral lesions caused by these. We have already studied the manifestation, the clinical presentation of and signs and symptoms of the patient presenting with the disease caused by the virus, especially the oral manifestation. Now, among the oral manifestation, we'll just compare and contrast the oral ulcers caused by them, the common oral ulcers. So here we have primary herpes simplex, HSV, herpangina, Coxsackie, type A, hand, foot, and mouth disease, also Coxsackie, chickenpox, herpes zoster causing shingles as primary infection causing chickenpox, and then EM, erythema multiforme. On the right side of this slide, we have an approach to diagnosis. Have approach to diagnosis, right? Which includes single episode of an ulcer can be due to trauma, drug, iatrogenic, for example, dentures, braces, also known as braces. Then we have infection. So we have trauma, drugs, iatrogenic, and infection. And among infection, we have viral infection and bacterial infection. So bacteria, you already know ANUG, Vincent's, syphilis, gonorrhea, tuberculosis, histoplasmosis, and rhinoscleroma. And in viral, we have HSV, especially primary gingivostomatitis, especially in children. Then we have varicella zoster virus, VZV, zoster, and chickenpox. Chickenpox primarily caused by the primary infection of VZV, varicella zoster virus, and then in adults, zoster cause shingles. Zoster or shingles. And then other than that, Coxsackie causing the type A causes herpangina and hand, foot, mouth disease, herpangina, hand, foot, mouth disease. And then we have rubella, measles, and Epstein-Barr virus. Nothing new, it's the same, a good revision so that you can revise and reproduce at the time of exam. Okay, let's go to the next, the first one. So in my presentations and lectures, usually you will find an order. You will never be disordered, disoriented, and you will never get lost in the slide. So there will be an order. So for example, here we have 1, 2, 3, 4. So the next slides will be according to the order, so that you can remember it fully and according to this, right? So it's helpful. I have seen it is helpful. Now we go to the first, acute multiple ulcers, which is caused by herpes simplex virus. So this is known as primary herpes simplex. Okay. So onset after 6 months and peaks within 2 to 3 years. So primary herpes simplex infection causing acute multiple ulcers, acutely but more than one ulcers, acutely but more than one ulcers. The onset is at 6 months, after 6 months, and peaks within 2 to 3 years. What are the clinical features? Prodrome. What are the prodromal symptoms, or what is prodromal syndrome? Flu-like symptoms, which includes fever, headache, myalgia. Myalgia means pain in the muscles, muscle ache. Then we have lymphadenopathy. Excuse me. Lymphadenopathy, malaise, fatigue, vomiting, nausea. So we have prodromal symptoms or prodromal syndrome or flu-like symptoms, which are 1 to 2 days before appearance of local lesion. Remember, this is an acute. We are studying acute. So your main focus should be here, acute. It should be within 1 week, less than 1 week, 1 to 3 days, 2 to 3 days, 3 to 4 days, like that. It should be like this. So prodrome are the symptoms which appear 1 to 2 days before appearance of the local lesions. So we have prodromal symptoms, flu-like symptoms of the child, and followed by local lesions. So the patient when the patient present to your clinic, he may show you rash, or he or she or their parents may show you a rash, and they start with this. He has rash on face. Maybe some parents are smart enough to notice that it started where? Early stages, it started from the face, behind the ear, on the chest, on the thoracic cavity, from the abdomen, following a neuronal pattern or dermatome, right? So you need to see. So the patient will say, my child had a fever 2 days ago, 1 day ago, yesterday, and then or just say my child had fever, and then suddenly we have a rash. And then you look at generalized lymphadenopathy, for example, especially cervical, and then there is lymphadenopathy, and there is malaise and ill-looking child, right? Febrile child. So maybe primary herpes simplex virus. Okay, good. And then after that, generalized acute marginal gingivitis. So we have generalized spreading all along the gingiva, and then we have marginal along the margin gingivitis. Multiple vesicles turn into painful bilateral ulcers surrounded by erythematous halo. Here, extensive version. Multiple vesicles turn into painful bilateral ulcers surrounded by erythematous halo. So there are, you see, if you can visualize this, it's like 2 yellow spots, almost like 2 yellow spots, this part. Okay, let me just clear everything and then focus here. Okay, this color is not good. Let's focus here. It's like bilateral ulcer surrounding by a red halo, red margins, red surrounding, right? Mainly keratinized gingiva, and then mainly at anterior area of oral cavity. So this is at the anterior area of oral cavity, and you can see here tongue is not spared. And other than that, if you can see this part, if you can see this part, we have an ulcer also on the lower lip. So anterior area of the oral cavity. So what do we need to remember? Prodrome 1 to 2 days before the rash, and the prodromal symptoms you already know. There is marginal gingivitis because we are now focused on the oral manifestation of this disease. And then, you know, bilateral ulcers look like bilateral ulcers surrounded by red area and involving the anterior area of the oral cavity. If you reproduce this much, if you remember this much, that's absolutely fine. Now we go to the second part, herpangina, the second ulcer causing in the oral cavity. Also ulcer causing causative agent of the oral cavity, which is Coxsackie type A4 causing herpangina, affects children from 3 to 10 years age. Just remember, affects children, affects mostly children. Okay, so it also has a prodrome, but it is milder than herpes simplex. So the prodromal, the febrile stage, the anorexia, the malaise, the lymphadenopathy will be not as strong as found in the herpes simplex. It will be a milder form. And then you can see sore throat and dysphagia because the ulcers are found in the soft palate towards the uvula and the pharynx. That's why we have sore throat appearance, and then we have dysphagia, difficulty during eating or swallowing. Yes, because we have ulcers, so it's difficulty and some pain. Ulcers mainly at posterior area of oral cavity. So this is how you differentiate, differentiate herpangina with herpes simplex. Herpes simplex involves, primary herpes simplex involves anterior area of oral cavity in relation to the oral manifestation of this virus. And then herpangina, Coxsackie type A virus involves posterior area of the oral cavity, including soft palate, fauces, or the pillars, lateral pillars, tonsils, and posterior pharynx. Ulcers smaller than herpes, more painful. So the prodromal symptoms are also milder than herpes. Ulcers are also smaller than herpes. So we have milder than herpes, herpangina. Smaller than herpes, herpangina. So herpangina looks like herpes, but it is angina. It's little pain. It's less or milder than herpes, because as compared to herpes, the prodromal symptoms in herpangina, Coxsackie type A virus, is milder than herpes, and the ulcers are smaller than herpes, but more painful. That's why we have angina, pain. Okay, you remember angina with pain, remember? So we have chest angina and then that. Okay, so prodromal symptom milder than herpes, ulcers smaller than herpes, but more painful than herpes simplex oral manifestation. Herpes one involving anterior of the oral cavity, anterior area. This is involving posterior of the oral cavity. Herpes was having marginal gingivitis. This is having no marginal gingivitis seen here. And this herpangina is usually seen in epidemic areas when there is one area and a lot of cases are appearing. So you can say, okay, this looks epidemic, so maybe it's herpangina. Okay, this is how you try to diagnose and distinguish. The third one, hand, foot, and mouth disease, also by Coxsackie virus type A16. From 8 months to 33 years, it can happen. 75% under the age of 4, found in the children, thank God. Also in the, easy to remember. So whenever you see the term hand, foot, mouth disease, you remember Coxsackie virus A16, and you remember the fingers, 5, 10, 16. Remember in the last slide, we said 5, 10, and 15. We said 5 fingers, or both hands we have 10 fingers, and 16 if someone has extra finger, right? So these are type A pathogens, types of Coxsackie A virus causing HMFT. Okay, perfect. So mainly on the extensor surface of what? Extensor surface of hand, foot. Extensor surface are these surfaces, but not limited to the extensor surface, because on the flexor surfaces you can also see this, the spread of these lesions and around the mouth. Okay, clinical picture. What is the clinical picture? We have low grade fever, prodrome. Okay, maybe when we have fever, it's definitely there will be malaise, fatigue. The child will be ill looking. There will be lethargy, myalgia. Yes. Okay. And then we have oral vesicles and ulcers more extensive than herpes. Why extensive? What do you mean by extensive? How you remember extensive? It is extended to hand and foot. From the mouth area, it has extended to hand and foot. Just how that's how you remember. The oral vesicles and ulcer are more extensive, not only to the internal of the oral cavity, but surrounding the oral cavity, and also extended to hands and mouth. But here is just remember oral. Just they have notified oral. The oral is not only in the internal cavity or internal oral cavity, but we also have externally present around the or peri-oral cavity, perilabialis area around the lips. So oral vesicles and ulcer are more extensive than herpes. Mainly palate and buccal mucosa involved. Buccal mucosa, buccinator muscle, cheek from the inside, the mucosal membrane from of the cheek from the inside, right? So the italicized, this form, the italicized is, I have written, it means that all the progression of their rash, basically how the rash starts, how it progresses. So how the rash starts here is macules and papules on the extensor surface of hand and feet is the distinguishing feature of hand, foot, and mouth disease. Perfect. This should be a revision class. Okay. Examine hands and feet for maculopapular lesions, macules and papules, and vesicles if there is acute stomatitis and fever. Vesicles, fluid-filled blisters around the oral cavity, causing acute stomatitis and fever, hand, foot, and mouth disease, epidemic area, hepangina. You need to distinguish. Both are caused by the same virus. No epidemic here. Okay, perfect. Now we go to the next part, which are varicella zoster virus causing chickenpox and adult manifestation of the zoster causing shingles. What is chickenpox? You already know. Primary infection of varicella zoster virus. If someone cannot say this or will not say this, doesn't make any sense. Chickenpox is the primary infection of varicella zoster virus. Have repeated enough times. 32 people and remaining 30. Okay. So we have two lesions, cutaneous lesions and oral lesions caused by the chickenpox in children, right? But focus is here on oral lesions because we are studying stomatology. Let's see the cutaneous lesions. Maculopapular lesions, same as HFMD, then turn to vesicles on an erythematous base, on a red base. In the red area, red base, we have a maculopapular lesion, which turns into vesicles by containing some fluid, the vesicle, yeah? Vesicle, yeah? Okay. What are the oral lesions? Chickenpox sores in your mouth. However, don't look like the chickenpox blister on your body. So chickenpox, if the extended to the mouth, it does not like, is not the same as the manifestation of chickenpox on the skin, because on the skin we have different anatomy. We have keratinized squamous cell epithelium, we have hair follicles, we have sebaceous glands, we have glands. So the manifestation or the clinical picture of the vesicles of the oral chickenpox and on the body will be different. So do not confuse yourself. These sores, which sores? Oral one, because we are talking about oral lesion. These sores look like raised bumps, raised vesicles that last about a day, that will last for only 24 to 48 hours. Then they transform into ulcers, oral ulcers. We are talking about the oral ulcers. That's why they transform into ulcers that are shallow, not deep, shallow, yellow, shallow and yellow. Come on. Shallow and yellow, right? They are shallow and yellow. It rhymes. Can we? They are shallow and yellow. They are shallow and yellow. Perfect. That's how we remember. They are shallow and yellow. The ulcers are shallow and yellow because after one day they transform, right? They also do not crust over like the chicken pox found on your body or your skin. You remember something from this class? Okay, at least you try to remember. Shingles, oral shingles. Yes, it looks like this. You see on the roof of the mouth. This is also the roof of mouth. This is a mirror actually. If you see here, this is a mirror showing the roof of the mouth, and you can see the oral manifestation or oral shingles. There also is a prodrome. There is also a prodrome. 2 to 4 days where there will be shooting pain, paresthesia, burning sensation along the course of nerve. Same as bodily manifestation or of the shingles, which is also along the course of nerve. How the vesicles are there? We have italicized form. What is italicized? Why I use this form? So that you can remember the progression of these vesicles or the lesions. Here we have unilateral vesicles, does not cross over on the other, on the second, it stays ipsilateral. It does not go towards the both sides. That's why you can see the left side of the patient looks totally different than the right side of the palate of the patient, because it involves ipsilaterally, unilaterally. It does not cross the neuron, the nerve path does not cross. It comes to the one side. Yeah, you can see here clearly one side looks unaffected and the other side is rough, have some pseudomembrane, grayish pseudomembrane, oral shingles, unilateral along the course of the nerve. Unilateral vesicles on the edematous base appear as clusters, a lot of clusters along the course of nerve, along the course of nerve, along the course of nerve, shingles along the course of nerve. The most diagnostic manifestation is unilateral appearance of the lesions, either on the body, trunk, especially, or abdominal area, or on the oral manifestation, oral shingles. We have unilateral appearance of lesions. Why I make mess? So that you can see through the mess and try to read it. And this will at least make you read once. That's why I make mess. Unilateral appearance of lesion. Unilateral appearance because along the course of the nerve, along the course of the nerve. Shingles. Perfect. The typical symptoms of oral shingles. Typical symptoms of oral shingles. Oral manifestation. Acute oral ulcers. Symptomology. Includes a tingling or burning sensation. Tingling and burning, burning sensation, shooting pain, paresthesia, tingling, burning, shooting pain, prodrome, oral shingles. The typical symptoms of oral shingles include a tingling or burning sensation in the mouth, of course, oral shingles, come on. Facial tenderness, or tooth or mouth pain. So close to the tooth that, of course, it will cause tooth pain and definitely the mouth pain because it's along the course of the nerve. Nerve goes to the dermatome, dermal area, mouth, tooth pain, facial tenderness, tingling or burning sensation, shooting pain, paresthesia along the course of the nerve, oral shingles. Perfect. Last but not least of the acute ulcers, last but not least of the acute multiple ulcers is erythema multiforme. Why I took time is because I like it. Erythema multiforme, EM, affects children and young age and rarely after the age of 50. Clinical pictures, no prodrome, no prodrome. Okay, so no prodrome. Unlike others, there is no prodrome. Unlike others, systemic and local lesions appear together. There is no fever followed by no rash, blah, blah. There is the systemic and local lesions appear together. And a very rapid onset, of course, is acute. We have multiple lesions, multiple ulcers. What are the oral lesions? How the lesions progress? Bulla or vesicles, fluid containing on an erythematous base, then rupture. Rupture to make appearance like this, rupture to appear like this. Appear like what? Lesions orally are anywhere, but lips are more prominent. All these pictures are focused on the lips, 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 lips. Yeah. So we have multiple vesicle, rupturing, rapid onset, destroying the lips. Okay, kind of involving the lips. Lesions orally are anywhere, but lips are more prominent. Where lips are extensively eroded, the mucus is eroded, and a large portion is denuded of epithelium, is void of epithelium. The epithelium is gone, is destroyed, is denuded, eroded, erosion on the lips, extensive erosion on the lips. Whereas rapid onset, no prodrome, especially children and young age. What else? Rare gingival involvement. Excuse me. We had a gingival involvement in primary gingival stomatitis, herpes simplex, and that was the first of the acute multiple ulcers, and now is the last of the acute multiple ulcers, which also rarely involve gingiva. So rare gingival involvement is most diagnostic. So it reaches from the lips, goes inside, involves rarely gingiva, most diagnostic, late stage. Lesions are larger, irregular, deep, and often bleed and there are tissue remnants. So just imagine if you just scratch it, or someone try to use their tongue to salivate it, and when the saliva will dry, it will make it more dry than before. It will be more dry than before. And then if you have somehow during eating or with your teeth accidentally punctured it, it will bleed. And there is no regularity in there. There's no regular shape. It's irregular. It's deep. That's why it bleeds. Deep means it has reached to the arteries, lower arteries, bleed. And then the tissue can erode and the remnants can fall. There are tissue remnants hanging or falling. And you look like this. What do you use? You use some soothing gels outside. Yeah. Okay, second, the first one was acute multiple ulcers. Let's just revise it. Acute oral ulcers, we had multiple oral ulcers and recurrent oral ulcers. In multiple oral ulcers, we had acute and chronic multiple ulcers. Among the acute, there were herpes simplex virus, herpes angina, hand-foot mouth disease. Herpes angina and hand-foot mouth disease was by Coxsackie A. Chickenpox, herpes zoster, VZV, varicose zoster virus, and then we have erythema multiforme. Primary herpes simplex, primary gingival stomatitis, marginal gingivitis, anterior area of oral cavity. Herpes angina, milder than herpes simplex, posterior area of oral cavity, milder than herpes, ulcers smaller than herpes, but painful, more painful than herpes. and posterior area of oral cavity. Anterior area covered by herpes simplex, posterior area covered by herpangina. Herpes simplex virus, Coxsackie A virus. Herpes simplex, marginal gingivitis. Herpangina, no marginal gingivitis. Hand, foot, mouth disease also by Coxsackie A, but low grade fever. Extensive around the oral cavity, around the lips, also extended to extensor surface of hands and feet, but not limited to the extensor surface because flexor surface also involved. Sometimes there is acute stomatitis and fever. Chickenpox and shingles. Chickenpox oral manifestation, shallow and yellow. Shallow and yellow. First, there is raised pump vesicles, then they rupture, transform into ulcers, shallow and yellow chicken pox. Chicken gives an egg with a yellow yolk. When they are chicks, usually are yellow in color, shallow and yellow. Oral shingles along the course of the nerve, prodrome along the course of the nerve, unilateral vesicles, ill-looking, irregular along the course of the nerves. Unilateral appearance of lesions along the course of the nerves. Cluster of lesions, unilateral along the course of the nerves. Tingling and burning, tooth, mouth pain, facial tenderness along the course of the nerves, unilateral. Finally, erythema multiforme. No prodrome. Among the 6, this one we have studied no prodrome. Love's lips, lips diagnostic. Rare gingival involvement, most diagnostic. Larger, irregular, deep, bleeding lesions. Tissue are scraping, but there are tissue remnants found around the lips. Perfect. Revise. Good revision. After the break, we will gonna do chronic multiple ulcers, but we are not going on the break right now. We are looking at our 31 participants, which were previously 32. Roll number 08, Adnan. Roll number 08, Adnan. Last week of the class. Roll number 26, Irfan.
Yes, sir.
Okay, can you differentiate in your own words between the primary herpes and the herpangina, the oral manifestation? Can you try?
Yes, sir. So in primary herpes simplex, there is a prodrome of 1 to 2 days, and there is fever, lymphadenopathy, and malaise, vomiting, and there is marginal gingivitis, and mainly keratinized gingiva, and most commonly involve the interior area of oral cavity. But in herpangina, so there is prodrome of less days, only anorexia malaise, and also there is most no marginal gingivitis and mainly involve the posterior area of the oral cavity.
Okay, perfect, perfect. Thank you so much. So, prodrome is milder and ulcers are smaller. Okay, herpangina ulcers are smaller and prodrome is milder than herpes. Perfect answer. Okay.